Good morning, everyone here on Zoom. Let's get started. Starting up Facebook as well. Good morning, everyone over on Facebook. We got a slightly different venue this morning. I am recording from elsewhere in my home because I've got guests in my house. My son came this weekend to visit me, which is always a happy time in my life. And as a result, my office slash spare bedroom is being used otherwise. So I welcome you guys into my living room. I hope everybody's doing well. It is another gorgeous day in Portland, Oregon, and we will likely be going out and enjoying it a bit later today. A good long walk. I missed our colleagues at Parker University this weekend. The Parker and the big annual event in the big annual event for Parker in Las Vegas is going on this weekend. If any of you guys happen to drop in from Parker, especially over here on Facebook, then by all means do join us and give us a live bit there. Let's see. Looks like we just had some trouble with Facebook, so we're going to restart that. Okay. Yeah, the Parker event this weekend. I'm sorry to miss, but I had other commitments. I'm thinking I might wind up showing up. Might wind up showing up for the event in July. I think they're having a NeuroCon in July. Hang on one second, guys. This Facebook thing is giving me trouble. Let's see if that work. Okay. All right, there we go. Facebook, take two. Maybe that'll work. Thanks for coming in over here on Zoom, members. Appreciate you joining me this weekend. Yeah, I haven't checked to see who was going to be at the NeuroCon in July. That's going to be down in Dallas. I'd much rather go to Dallas than to Vegas, quite honestly, and would be much more interested if there's a little more of a focus on neurology instead of the 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 standard kind of human optimization speakers and such that tend to be at the Parker seminars. Let's see, this week, what we want to talk about. I had some good cases in the clinic this week. Hopefully, some of you guys that will join me at the Seattle show a couple of weeks ago will join in today and share some of your clinical experiences this past week or two with the NeuroCentric approach. I did get some feedback from some of the members that, especially like Mark, were very pleased with the shoulder interventions. Actually had a lovely one of those this week just a couple days ago with powerlifter. I might pull that up in a wee bit. I had some video that I posted as a reel on Facebook, and I was thinking I might try to flesh that out. But candidly, I'm on Facebook so little anymore that it seems like whenever I am, my audience reach has dropped off so much that I barely have anyone. I'm not showing up in anybody's feed. That's why I'll try to get you guys over here on Zoom so we can have a civil conversation. Okay, so let's launch into some case studies for the week. The first case study that I would like to discuss showed up a couple of days ago. It was a let's see, patient presents as a 42-year-old female, referred over by her chiro, who is also a member of our online academy, which you guys can be members as well over there on Facebook if you're not already, by going to the link that should be there on the bottom of your Facebook live feed. If you go to neurocentricapproach.com, you'll find links to the online academy. That's 35 hours currently of online continuing education that is PACE accredited for chiros. So the cool part too is that those of you that are members of the online academy can come and join me at the in-person courses. And the in-person courses are 12-hour courses. Next one is April 20 and 21, right here in Portland. Going to be at Evolution Healthcare and Fitness, Dr. Brad Farah's lovely facility that I used to have an office in once upon a time. But if you are a member of the online academy, you get $100 off of those in-person courses when we hold those. Dr. Glenn Harris is on here as well. I think it's worth giving a shout out to Glenn's very cool idea for next weekend. Those of you that are interested in learning a bit more about lumbar discs, how they can become sources of nociception, how that can blend into other things. Glenn has come up with a very cool online symposium idea on the I think it's the 93rd, 95th anniversary of the historic Mixter and Barr paper, where they identified the lumbar disc as the source of, at that point, pain. But there's going to be some pretty interesting presenters there. Stuart McGill is going to be there. I'll also have James Cox, Mr. Reflection Distraction. Kathy Dooley is going to be there. It'd be nice to see Kathy again. And there are some others as well. Glenn, you want to come on and talk a little bit about how folks can get into that?
Absolutely. Thanks, Philip. We also have Mark Irwin, who's going to share with us his groundbreaking research on the process of the degenerative disc and the process of discussion on manual therapy of the management for disc, both with radiculopathy and without radiculopathy. Cesar Incapi, who's a researcher, chiro in Switzerland, is going to also talk about manual therapy for the disc with and without radiculopathy. And we'll have a bit of a discussion on, the risk management and such for that. We're also going to have Dr. Varsha Kumar, who's going to give us a little synopsis of the imaging in behind the disc. And basically, it's just to celebrate the 90th anniversary of the classic Mixter and Barr paper from the New England Journal of Medicine. I'll throw the link in the chat for those that are interested. It's a week away. Phil's going to be presenting a whole section on assessment, but really looking at his symptom modification procedures that he's kind of got quite an art to doing. So we look forward to that next week there, Philip. Thanks for the shout out.
Oh, no worries. And Glenn, if you can keep two balls in the air, go over to the Facebook live stream and see if you can maybe drop a link in on that. And if not right now, then later when that goes up so that folks can find their way to it.
Sounds good. Thanks,
Thank
Philip.
you. And again, I appreciate what you do to try to take the knowledge bar up on this kind of stuff, Glenn. Glenn is also going to be hosting me in Toronto, and we are looking at whether or not we want to do a 4-day in a row or two separate courses for upper and lower quarter in Toronto. I'm currently looking at dates in November. Okay, so let's get back to our case, recalling our 42-year-old female presenting on referral from her chiro, who's a member of the NCA Online Academy. Patient is 4 months, I believe, status post an anterior cervical disc fusion, ACDF. And you guys that have seen these or have not seen these, you're going to get an interesting incision about inch or two wide right here in the anterior, hence A part of the neck. And in this particular person at 42, that's kind of an unusual situation, eh? So in that particular individual, she did not have a history either of radiation, of any kind of symptoms into her arms or hands. Also, no symptoms in the lower extremity for those of you tracking myelopathy here. Her primary ongoing symptoms were hypersensitivity in the posterior neck and upper trapezius. And when she had gone through a couple of rounds of physical therapy with very little improvement in that. And when she saw her chiro, he just punted and sent it over to me. Now, you guys that have been playing with this for a little while might start coming up with some ideas about why she might have hypersensitivity, hyperalgesia over the upper trapezius and the posterior neck. Let's just take all of this information off of the table immediately about anterior cervical disc fusion. If you had a person that had hypersensitivity in this area, complaint of 1, burning pain, 2, even the pressure of her shirt and jacket and collars on that particular area is really particularly noxious. A few things should be coming to mind by now. One is what neurology actually services this area. And 2, of course, you're trying to develop somewhere in your mindset a narrative to explain why in hell someone could have those kinds of symptoms on the back part of their neck when the surgical approach was to the front right here. So hopefully you've got some ideas there, and we can explore those as we continue on. Patient was, when she came in, other issues that were of interest in her past health history. Hyperthyroidism. Recently, her levels were checked, so and were have not fluctuated significantly in the last several months. They are being managed by her PCP, and she's on levodopa. Also, she carries a diagnosis of anxiety, generalized anxiety disorder. And that is being managed medically as well, also by her primary. And she has some medication on board for that. So there's a couple of things that should start to make you wonder a wee bit about other things. Remember on our when we're doing our workups on our patients using the NeuroCentric approach. Let me see if I can call up one of our recent course presentations, and I'll throw a slide deck up, and we'll just talk about this for a moment. Those of you that are new over here on Facebook, sorry, you'll have to join the online academy to come play. Actually, I did drop the Zoom link in there for you on the Facebook Facebook Live today, so you should be able to join us there. All right, let me share screen and see what we got. So when we're doing our workup, just as a heuristic to keep us organized, I like to try to organize the neural structures we're evaluating from bigger neuro to smaller neuro, brain down to the cellular level. So as we were just considering this particular patient with the anxiety and also hyperthyroidism, we can consider the possibility down here at the cellular level, other systemic things that might be making her peripheral neurology a bit more hypersensitive. And those start to kind of blend into issues of central sensitization. Indeed, she did mention that her surgeon, kind of scratching his head, had noted that maybe she was just having an exaggerated reaction to the surgery and the trauma there. And she had a predictable response to that kind of input. He told me it was all in my head, and they really didn't give her much beyond that. And the physical therapist, this is a little input for some of you younger docs out there. If you don't know what's going on, it's okay to say that you don't know what's going on, but offer some explanation. Try to put together a narrative that kind of makes sense for the patient. Because when her providers literally, to her mind, just threw up their hands and said, "We've never seen this before," then that gives her brain one more place to take off and get interested in and start to become that much more overly focused on what she's feeling in this hyperalgesic area. So in this particular case, this individual, again, you got to read the room with your patient, was relatively savvy, and I felt could handle a deeper explanation of wind-up events and such. So I gave her an idea about each of those synapse points and how nociceptive neurons work. And at the end of that, she thanked me and said that that was the most in-depth description that she'd gotten. And that was all lovely. All right, so fine. We've started to lean in and produce the possibility in this particular patient's mind that perhaps essentially her overall neurological system in that particular area is a little bit hypersensitive by nature, dependent on things other than the surgery that went on. Okay. So then we moved into our physical exam. Range of motion, active range of motion in cervical spine was essentially normal throughout, although she was limited in primary symptom. Let's see, the anterior approach was on her left anterior side, and her symptoms were primarily on the posterior left aspect of the neck, with contralateral rotation, which was limited by 20 degrees, and cervical flexion, which produced contralateral pain. So we've got an opening phenomena on the left side, and we've got a potential tensioning of any superficial neurology in that particular area. She also reported that she had a radiation of symptoms up and she pointed to mid-cervical up the back of her neck, to the top part of her head. And that starts to get you, kind of make you go, maybe we've got something else going on, or maybe a couple of different nerves. But if I'm just keeping a laundry list, if she's got symptoms in this area, what's the cutaneous sensory for this particular area? We've got posterior rami coming off of the spine, right at the area where she's had her surgery. And you also have which nerves? Remember Erb's point. Erb's point, mid-belly of the SCM, we've got 4 superficial cutaneous nerves. Let me go over, I think I've got some. I have got, and I am failing this tech here. Give me a second. Okay, we can do this. Manning computers should probably be a little careful about how they expose themselves to such things. Did I just lose everybody? Sweet Jesus. Hang on, people. I'm so sorry. You guys that are over on Facebook, Glenn, I think you're also open on Zoom. There you are. Jesus. Sorry, guys. Okay, here we go again. Clever amongst friends. All right, so let's look at the back part of the head and consider superficial neurology. Remember, the patient reported that she had symptoms going up from the occipital, even mid-cervical, all the way up to the cranial area. And of course, we've got the greater occipital nerve. I'm sure all of you were jumping right on that one, but we also have the third occipital nerve that probably is under considered, but probably experienced by many of us in clinical practice on a daily basis. I do love this slide because it's a bit more practical and showing the underlying rotatory suboccipital muscles that we like to play with in this area, like the obliquus capitis inferior and the obliquus capitis superior. So we have a proximal relationship there with the third occipital nerve and these other nerves that come off of the cervical plexus right in this area. And if we look right around the corner over here, we've got the lesser occipital nerve and also the greater auricular nerve. Now, all of these are C2, C3. That's not the area that her ACDF was done. Her ACDF was low cervical spine, like most of your patients that are going to be getting this, right? Her ACDF was the C6, 7, actually. But what is the procedure for the ACDF? Well, when they make the incision here, they have to put retractors in and pull everything back, right? And it's with the retraction that I suspect we had a little bit of tweak of this particular neuro. Now, I'm not going to go on record anywhere other than right here in this kind of community and call that out because I don't know and I can't prove it. And then we open up all kinds of med legal BS. And I'm not going to mention it in that direction for the patient either, because it gives her one more thing, and now we've got something else to get upregulated about. So I start to think about the involved neurology, and I have her, we now have an index test, right? So what is her index test? It is contralateral cervical rotation and flexion. She also has pain on the opposite side with left rotation and flexion. And when I had her do the index and tested locally with some dermal traction right over that area, it was one of those lovely DTM moments where she got quiet and then kind of went, wait, it's gone. And you have that moment, and there I think in doing this kind of work, if you don't keep your ego in check, you can easily step into that moment with that patient and try to look cool. But if you think about the patient's process at that particular moment, she's come on board with an idea. She's got a laundry list of possibilities. She's been on the interwebs, and she's got all kinds of ideas about what kinds of major things might be going on that are going to take some sort of Herculean intervention. But all of a sudden, just tugging on the skin in that area improves her symptoms, and there's a searching mechanism. Now her mind is sort of going through, okay, what do I know about this particular area? So if you step into that and say, well, that's kind of fascinating, isn't it? Can you feel the depth at which I'm working? I said, am I working on a muscle right there? And she said, well, no, you're in the area over a muscle. And I said, now that's where your physical therapist was working based on what you were talking about, right? And she said that she consistently got worse when her physical therapist did manual therapy. And she noted in provocation that manual therapy in this area consistently made her worse. Palliative was leaving it alone and not exercising a whole bunch. Now, of course, we like an active care program, and she's pivoted around that, and she's mostly doing HIT programs that help her with her anxiety and such, but they're mostly lower body. So when we got in there and worked that particular area, her symptoms went away while my hand was there. And then I tried to reduce the amount of time that I spent there, given what she told me about her experience with the physical therapy. And I took my hand away and let her move. And as she moved, she noted that she had about a 75% reduction in her presenting symptomology after I took my hand away. And that continued for several minutes afterward. So we just kind of tabled that. And then we had a similar situation with the neurology up on the back part of her neck, radiating over the top part of her cervical spine and top part of her head. And once again, just using DTM in that area, lifting, I created a bit of space theoretically and got her able to move a bit better, and she had less symptoms in that area. Now, many of you might want to call me out on this at this particular stage of the game, because I've gone straight to the most superficial neurology, and I called that out first. But her symptom presentation is what kind of dictated this. Since she was experiencing hyperalgesia, if I'm going to try to do an opener at cervical spine to see if that helps, my fingers are going to be right over the area where she has her complaint, where my other thinking regarding the superficial cutaneous neurology as being the primary here, I would be muddying the waters with that a bit too much. And now I'm going to work backwards from smaller to bigger. And indeed, as we continued to try to do other movements, she had done McKenzie retractions and McKenzie protocols for retraction with rotation, retraction with extension and rotation, till the cows come home, and she was adamant that they didn't make any improvement, and they always made her worse. Well, it kind of makes some sense as well, given what we know about that movement and its reduction in the intervertebral foramen cross-sectional area in the lower cervical spine. So my thinking at this point is that we've got a person that is dealing with superficial cutaneous neurology that has been sensitized historically by her ongoing pain in that area, central sensitization here, and that we can potentially create some benefit by judiciously applying some local openers, if you will, using DTM. As the exam progressed and I started trying to work the deeper levels of neuro with opening maneuvers, with static openers and such, she steadily started to get wound up, and she's like, yeah, my pain's going up. She had presented with a 4/10, and now she's up to a 6/10. In this type of work, now that we've got her flamed up, and I've already prepared her for the possibility that the nature of the examination is somewhat provocative, but that we will then try to test different interventions and see if we can reduce that. She described her windup as being dull and diffuse and spread over this area, not pinpoint, sharp, and burning. So now I look at my patient, and she's in our visual exam early on, we noted an apical breathing pattern, and she's hanging out with a Gothic posture. So I call her attention to that and stand her in front of a mirror and have her take a breath and just kind of monitor her tidal respiration. And when she takes a deep breath in, we can both see that her clavicles are rising. And I asked her if she could take a breath in without doing that, without cueing her any further. And she couldn't. So I cued her with a hand on the chest and a hand on the belly. She gets the breath in the belly. Then we move around to the flanks and get a 4-point contact that Mark loves, that 4-point contact with 2 fingers on the posterior flank and 2 fingers on the anterior flank, and have her to try to localize her breath into all of those areas. So here we're kind of working a little bit into some of what Kabuki has done with their progressive loaded movement program in their lifters as an extension of what we've learned in the DNS programs as well, in regards to using the diaphragm for both creating stability while simultaneously respirating. And according to that particular model, if we don't have the first domino in place, going back to Paul Hodge's work in the mid-90s, showing us that when you or I reach for something with our arm or our leg, the first group of muscles that has to be on board are the deep spine stabilizers and the abdominal canister there. So if we see evidence here that hers is off base a bit, she's presenting with an open scissors and an apical breathing pattern, I'm thinking the possibility that if we can change that, we might be able to change her diffuse pain that's spreading over this area, which I suspect probably has to do with the chronic tension in the upper trapezius muscles, probably a low grade, as a result, low grade acidosis state in the tissues there, which then could be a nociceptive chemical trigger to the posterior rami. Just a thought. So we tried going into the breath and working that. I coached her into a breathing pattern for diaphragmatic breathing, had her let go of her shoulders, coached her into that, stood her up, provide a kinesthetic gentle cue of axial pressure downward on her head. She very much wants to get back into running. I typically, in a patient with this kind of presentation as a runner, they're going to run like a T-Rex with their arms up here and their shoulders up like this. And she noted that whenever she ran, she immediately had a flare up of her symptoms in this area. So as I put some downward pressure on her head, we could both easily feel that she had an energy leak right at the pelvis with a anterior pelvic drift on that. So I said, okay, just fix that. And with the kinesthetic cue, downward pressure, just steadily putting a little bit of a bounce there, she was able to organize herself under that so that she could have essentially an axis of support. And then I steadily, once she got there, applied a little more pressure. And I said, let me know if I'm hurting you. Am I hurting you at all? And she's like, no, that doesn't hurt at all. And I said, can you breathe in this position? Breathe diaphragmatically. And she was able to do that. And I said, now, can you feel how much effort this takes for you to organize yourself in this particular way? I said, does this feel like it takes a lot of effort? And she's like, no, this feels very relaxed. I'm like, right. You're merely putting yourself in a position where your skeletal, your skeleton can manage more of your load under gravity's pressure. Now you're magnifying that gravity pressure when you run, and every time your foot lands, you've got a 4 to 6 times your body weight of axial load through the skeleton there. So let's get you in that upright position while you're running and let the shoulders fall. And I want you to practice shoulder rolls while you're running and see if you can let that stuff go. Now, after we had done this coaching session and a little bit of breathing through that, I checked in again and I said, all right, how is your pain in this particular area that you had? We had ramped up to a 6 and she's like, it's down to a 3 now. I'm like, okay. So that's kind of cool. So we've triggered your pain and then done something to take it away. And I asked her frankly, I said, now, is this unusual? Once you've been ramped up in your treatment sessions previously with people doing manual therapy and such, have you been offered anything that gave you the ability to reduce your symptoms? And she said, no. So here we have agency, locus of control. And now we're working back into that top-down model of trying to give the patient something that they can do to help themselves other than reaching for what she had already said were her go-tos in that case were gabapentin and muscle relaxant, which she's willing to take, but they alter her cognition enough that it interferes with her work. Okay. So that particular patient, we left with that. I will follow up with that one in weeks to come. I, looped back around to the idea of central sensitization, and it could be that regardless of all of the other cool and interesting things that I talked about, that we're just looking at a need for the balm of time to downregulate her symptoms in this particular area. But in the meantime, what are we going to do to try to help with that? We give her some things that she can do that don't come out of a bottle, and we improve her ability to go and exercise and respirate well. So a more holistic kind of old-fashioned approach to that kind of stuff. And we'll check back in on that one in a few weeks and see how things are going with it. So, thanks to those of you for hanging out with us on that case. Anybody have any questions, comments, or concerns about that? And Mark, I am digging your background today, brother. You are somewhere warm with palm trees and palapas, I saw. You got to unmute, brother.
So my question is, you were successful on DTM. I don't remember whether it was lesser occipital or greater occipital nerve, but are you having the patient do that at home?
Yes, absolutely. The primary endpoint for her, and this is one that I've seen some of my students kind of trip up on here. Erb's point is not a nerve. Erb's point is 4 nerves. So if you're doing DTM at Erb's point, and the patient has you get buy-in, that's great. That's a potential mechanical interface point that you want to pay attention to. But then you want to drill down a little bit further. Her presenting symptoms then go where from there? They go this way, which would be supraclavicular nerve.
Supraclavicular, right.
And then they go this way, which would be typically lesser occipital and greater auricular nerve. So I then went and skin rolled over each of those areas and looked for areas where the superficial fascia seemed to be a bit more densified, you know, thinking about the Secco sort of model there, a little bit of a matting down of the skin on the muscle layer underneath. And as I rolled over all of those areas, she reported one pain, and I felt that the tissue compliance was off there. So I gave her that to do at home, and gave her the coaching to titrate that to tolerance. That if she's doing that in a way that she finds that it consistently ramps her symptoms up significantly, maybe take it back a notch. But if she does ramp her symptoms up, then she could practice the breathing techniques that we talked about to try to downregulate that. We also worked on graded exposure inputs as well, and with the idea that one, cognitively, she could override this, and just talked with her about that superficial neurology. And I went down to the level of her leg, and I just skin rolled on her leg. And I said, now, does that hurt? She said, it's a little noxious. I said, right. But you know why and how much that should be off or painful, right? And she said, yeah. And I said, now compare that to the way that you feel in this area when we skin roll in that area, and think about that. So, and she's like, yeah, you're right. And she says, the input is exactly the same in both areas in terms of quality and the depth of the work, but this one feels a lot worse. I said, yes. So while you're doing that, think about that and tell yourself, tell your mind, it's okay. Just let it move and let it hurt just a little bit. And maybe even try hot cold contrast, something that's a bit noxious, to expose that neurology to a variety of symptoms, or a variety of stimuli rather, hot, cold, mechanical, all of those things, to try to normalize the firing threshold of that particular neurological circuit that's going on. So those are my inputs for her on that. Mark, where are you?
I'm in Cabo San Lucas.
Awesome. I am, you don't have much prettier day than what I've got here in Portland, I will say. It's pretty nice here right now.
Well, I'm a mile in the Sea of Cortez this morning.
Awesome. Awesome. All right. Well, I am looking forward to seeing you in April at our course in Portland, April 20 and 21. And I thank you for joining us in Seattle when we were there. I'm going to mute you right now unless you got another question, brother. Okay. Anyone else with any questions or input? Okay. I had another interesting one a couple of days ago. I think before we leave that one, I do have one more slide I'd like to share with you. If I can get over to it. You to see the netter plate here. Um, so I particularly like this one in this case because we can see the SEM reflected back, and you can see the contents of what's under Herb's point there. Other pertinent rule outs in our history on this particular patient. Do you have any difficulty swallowing? Do you have any difficulty with breathing? Any changes in vision? Any changes in smell? Did a cranial nerve exam and things all checked out on her. But one to keep in mind here on these kinds of things, and it also comes in as well in some of our patients that have had motor vehicle accidents with their head rotated. When they get hit from behind, maybe checking their phone or talking, trying to get something out of the back of their car when they get struck from behind. And that in those particular situations, we've got some concern about apical or alar ligament rupture as well, and some upper cervical instability. But another structure that will sometimes get injured in that will give you a stretch on the accessory nerve, the spinal accessory nerve there. And you guys recall that that's motor innervation to the SCM and to the upper trapezius. And in our cranial nerve exam, when we do the shoulder shrug and then possibly the lateral head rotation, that's what we think we're testing for on that. Well, one of the other things that you might note with that in those patients, if it's chronic over a period of time, that patient will often show up with a sloped shoulder, a slumping shoulder on that affected side. So if we have enough damage to the accessory nerve that the motor to the upper trapezius is reduced, that patient will have an asymmetrical shoulder height, and the affected side will be the low one. But because you and I we're all kind of conditioned in our training to look for muscle hypertonicity, we all go to the upper trapezius on the other side that's hypertonic. And when we palpate that, it is painful. And the patient says that it feels good, but that's not the one that's the problem. The problem's actually on the other side with the reduced motor on the side of the accessory nerve. And that might be something, if it's a traction injury, neuropraxis sorts, that doesn't come back. Or it could be as well that you just need to prepare the patient for the likelihood that that's going to take a good long time. So I thought I would share that one as well for you guys to keep in mind. Let me go over and show you a couple of videos that I took this week. These are with patient permission. This is a patient of mine who also happens to be a master's level world record holder in sport of powerlifting. And she presented with right anterior shoulder pain this week. She's 6 weeks out from competition. And she's having anterior superior shoulder pain over that area. And her index movement was bench press with over 135 on it. Her competition goal is going to be her working weight right now for 1 or 2 reps is about 175 on her bench. And 135 or less even was causing the symptoms. And it was a motion arc on the bench such that when she dropped down, it was only painful when she got to the humerus roughly parallel to the floor. And then below that, she started to have pain, and then it went away at the very bottom. And then as she tried to press out of that, she had pain through the exact same motion arc. So got a painful arc on that particular movement. And in this one, since I'm a little bit more familiar with working with these particular athletes and know the mechanism often the mechanism of injury here, I went straight to the cervical spine. So here's a quick video.
I'll just let you know we're not getting the audio.
Oh, thank you, Glenn.
You
Okay,
could just you can maybe
got it.
restart it and just share the audio.
Okay, just all right. Just got a just found out that we are not able to hear that. Okay. So here's what I did, guys. Take you back to where I was. So I provided, she was having pain in that motion arc right over the front of the shoulder. I stepped behind and provided a traction over the cervical spine, and her pain went away. And so the pain goes away then, and then we have a continuation of the benefit for several reps. So I've got in this particular person, one, this is not her setup for the bench press. So her setup is going to be, for those of you familiar with a competition powerlifting bench, she's going to be going into a lot of cervical retraction and what will be effectively cervical flexion. So there'll be a little bit of a closing and then a little bit of an opening on the IVFs in the lower cervical spine. So I could conceive of the possibility of trying to get her to alter her setup position, but this is a world record holding athlete 6 weeks out from competition. And I'm not going to go in there and say, we need to change your setup 6 weeks out. That's folly. So at this particular point, I'm thinking, how do we create more space? Can we create more space consistently enough over a long enough period of time to take essentially call it a bruised nerve root down a touch and reduce her exposure to those bruising mechanisms over the course of her treatment and the next 6 weeks of training. My experience with these athletes, one of the first places that you're going to see that happen, the exposure to that bruising mechanism, is on the racking of the bar on a back squat. And a lot of these athletes with bench and the predilection to just working in this plane and ignoring this plane, they often wind up with reduction in shoulder mobility that over time, just getting their hands into the position of getting the bar on their back to do a back squat becomes harder and harder because they lose extension capability in the upper thoracic spine. So then the body borrows extra degrees of movement in extension at the lower cervical spine, and there you have the mechanism for the sensitization of those nerve roots over time. And this will commonly show up later in the training block for these athletes as they get closer to competition. So I went over to Lori and we set up once again the same thing. Again, I apologize for not having the sound available, but you can see, and I'll talk through over this. We set her up on bench, and we had her to get her set up and see, after we had done the things that we had previously done, if there was going to be carryover to this. So she sets this up with a much smaller weight than what she'll be working with, but enough to provoke her symptoms. She had pain in the motion arm. And then I went in that position to see if we could still get benefit. I just provided cervical traction with her in that position. And I'm noting here that we've already done McKenzie retractions and retractions with extension and rotation, and we did static openers with no benefit. And I do this, and she had no pain with manual cervical traction. So what did we learn out of all of that? Well, it looks like I'm going to have to go to Texas with this particular athlete and provide cervical traction for her while she's in competition, performing her bench press, which of course is a joke. So what I'm looking at now is essentially trying to create some space there. What are some ways we might be able to do that? Well, how about manual traction and or manipulation and or mobilizations in that area? Well, I did go trial that as well. I did manual traction. We went back in and tested using the clinical audit process there. And we didn't have any buy-in, no improvement on index with that. So I took it up a notch to grade 4 mobilizations. We retrialed the setup, didn't have any change on the index with that. So I took her back in and gave her an opening. So that would be a right rotation and left lateral flexion, cervical break at C5-6, and went back in, and she had no change in the symptomology from that. So I'm like, okay, well, I can see this patient 2-3 times a week. She's a sponsored athlete, so you know, I can see her as much as I want, and you know, she doesn't have to pay out of pocket for it. But I can see her 3 times a week if we want, but I've not demonstrated an improvement on the index with that. So I'm still looking for something she can do to improve the symptoms when she has it, so she can do it before she trains. And I went into, you know, borrowing from some of Donnie Thompson's kind of work and some of the gym fails that you see on YouTube these days. I got some jump stretch bands, the big wide ones that are like 2 inches, 3 inches wide. And we hung it from one of the monoliths in the gym and had her do a wrap on it under the occiput, and then gently drop, you know, bend her knees to the point that she's got traction on the cervical spine, and maintain that cervical traction, and then do pulses into that. Nothing violent. We're just getting some traction in that area. So now we've got something that she can do right there in the training environment, both at the event and also in her training sessions, to try to do that. And when we went back and retested her index on the bench after that, she didn't have any pain in the shoulder after that. So we've got something that she can do at home. So incidentally, I did go downstream. The primary downstream nerve you're going to find on these shoulders with this particular population, the involved neurology is usually going to be the suprascapular nerve, which you guys know is motor to the infraspinatus and the supraspinatus. And it also provides articular sensory innervation to the posterior third of the glenohumeral joint. So if the patient's got pain on the superior and posterior aspect of the shoulder, that's a likely target. And if you get in there and palpate over the course of the suprascapular nerve anterior to the, if you, you guys can all do this on yourself, Ross, I see you're going right to it. Go to your clavicle, go over and drop it into the subclavicular space, or what is that? Maybe that's the posterior clavicular space, I forget. Nudge on until you run into the upper trapezius, and your target area is just underneath that. And just kind of palpate laterally all the way until you bump into the acromion there. And that's going to be probably the supraspinatus under your hand, and somewhere between your finger and the supraspinatus is the subscapular nerve or suprascapular nerve. You can trace it all the way out to the scapular notch. Usually those are high likelihood places for a mechanical interface problem, right as the nerve takes a turn around that corner. And those are your quote unquote trigger points that we find in the supraspinatus and infraspinatus. Interestingly, too, on her, since her pain was also on the front side, I put her in a position supine on a bench in clinic and internally rotated the humerus. And first I palpated the humerus just anterior to the acromion there, and that was not painful. And then I steadily rotated internally her humerus until we got to the point where she was actually sensitive. And there again, suprascapular nerve, posterior third of the joint is typically the innervation pattern. And I've got to rotate her forward to get to the irritated neurology. And I did some TNM, some transverse nerve mobilizations over the nerve at that point, with her alternately tilting her head and such. And I still didn't get any benefit there. So again, recall that if you've got a nerve that is sensitive here because of something going on in the spine and you're not clearing the spinal issue, then you can go out and mash that painful nerve until the cows come home. And at best, you're just going to get temporary benefit. So in your clinical work, if you're working in the periphery and your patient keeps coming back and saying, yeah, I felt good for a day. Yeah, I felt good for 12 hours, but the pain keeps coming back, then likely you've missed something upstream and you need to go and look for what's sensitizing that neurology. Okie doke. So we'll also track that one out over the next several weeks and see how that goes, because that'll be a fun one to try to get this world record holder out to set more world records. All right. So we are just over our typical allotted hour here. Does anyone have any questions, comments? Really appreciate you coming out and sharing a little time, geeking with me a little bit. Some of you might have seen some of the posts on the evidence-based chiropractic forum this week too about various reasoning. I'm going back and dusting off some old philosophy notes on various types of reasoning, deductive and inductive reasoning and abductive reasoning, and thinking about some of the ways that we involve all those processes in clinical reasoning. We may talk about that in future episodes too. All right, you guys, stay curious. And as you do, take the things that you learned and go out there and help some people. You guys are awesome. Go have a great weekend. Be well. I'll see you right here next week. Thanks for joining us, Ross. Cheers.
Thanks, Philip.